Chapter 20 is on sexual dysfunction and gender dysphoria. I'm not going to go into the paraphilias, but you can look over that on your own, but I did not feel like that was actually necessary, but some of it is quite interesting if you want to peruse through there. So we're going to get started, and let's get ready. As nurses, we are given basic education and able to provide information that is sufficient to qualify any journalist or generalist, sorry, not journalist, but generalist, to assess for sexual dysfunction and perform some type of health teaching, whatever is required. Misinformation about normal sex and sexuality is common. Think about kids in high school and how if you ask them some questions, some of the answers they'll give you are quite astonishing. And this goes on as we age, so if people are not given the correct information. So this lack of knowledge may affect an individual's actual sexual judgment. Sexual dysfunction is actually a disturbance in the desire, excitement, or orgasm phases of the sexual response cycle, or maybe even pain during sexual intercourse, such as genitopelvic pain or penetration disorder. Genitopelvic can actually be women. An example would be a woman who is in menopause may have painful intercourse once she has been penetrated. However, with men, it may be pain with penetration, maybe someone who has a hypospadias, and so they have the painful intercourse. So again, this could be coming from something hormonal, physical, psychological, or medically induced. So example is this I can give you, or maybe think about medications for hypertension. Well, these can actually interfere with normal sexual functioning and can lead to a sexual disorder. Hypertension itself can actually lead to erectile dysfunction. So general questions we need to ask our patients about when they're taking a medication. And sometimes it's hard for them to open up to us because they do have concerns or questions. So we need to lead them into that sexuality, letting them know maybe a medication that is for hypertension may prohibit them to be able to have an erection or a prolonged erection for men. So again, these can be a problem. Like I said, with the genitopelvic pain and penetration disorders, again, this can occur in men or women, and they feel pain in the genitalia during intercourse. And it's not really a problem with the erection or ejaculation problems at all. It's just actually with the penetration. Sexual problems can actually disrupt, can interfere and disrupt relationships. And so some medical conditions are listed on page 384 that actually can lead to these. Also, there's a table 20-1. Actually, it's page 285. 385. Good grief. And these are some medical conditions or either some problems that can happen from surgery that can cause some sexual dysfunctions. And so please look those over so you have an idea. Medications can result in a variety of those sexual dysfunctions that I said before. Some other ones besides erectile dysfunction can be a low libido. Something that might be medically induced, again, is someone who has hypertension, which can interfere with normal sexual functioning and lead to a disorder. So again, we need to make sure that we discuss sexuality with our patients when they're on medications, especially if it can actually interfere. So again, this is something that we maybe have to open up the door for discussion because maybe the patient doesn't feel adequate to give that information. So in looking at the nursing process, we're going to start with assessment, and you have some guidelines that we're going to follow. But before we can help our patients with sexual dysfunctions or disorders, we need to be aware of our own feelings and values about sex and sexuality. We also need to keep keep our own personal beliefs separate from our patient care in order to be able to maintain that an objective, professional, and effective attitude and care towards our patients. The setting should always be private and without distractions. So it needs to be in an area where they feel comfortable. Note-taking should actually be kept to a minimum. Makes individuals nervous when you're taking a lot of notes when they're having these discussions. Interviews should be free of any personal biases, any judgmental attitudes, and this goes for your verbal and nonverbal. Good eye contact, relaxed posture, friendly facial expressions. This can help facilitate the patient's comfort and their ability to communicate openly and be more receptive on part of the nurse. Medication, questions, and drugs that can cause issues are on page 387 in your textbook. And they also like to talk about ways to interview a discussion, and we're going to go over those in class. And that's table 20-2 and then 20-3 for the medications. On your assessment, you also want to make sure that you are thorough and look for cues and those non-behavior or nonverbal behaviors that they might be hiding or maybe having difficulty expressing their ideas. And we need to be able to help to encourage them to be able to express. We see a lot of patients who believe that sexual intercourse will cause a heart attack. So when we're talking to our patients, we need to dispel any incorrect thoughts that they may have. So we need to make sure that we are providing the education needed regarding their sexual activity when they go home, because many times that's left alone, and here you have this couple and they go home and they never ask the question, no one ever approached it, and they don't know if it's safe or not. Some of our other diagnoses that we'll see is sexual dysfunction, ineffective sexuality patterns, also to maybe the sexual dysfunction, altered body functions from medications, psychosocial abuse from a significant other could also be a cause. So we need to take our time and look back. As far as our outcomes identifications, we want to make sure that we can get them back to a normal activity and where they feel comfortable and they can actually go on with that through a positive experience through sexual functioning, and where it's not actually becoming a psychological issue. With implementation, we're going to look at pharmacological interventions and 7 of the psychosocial interventions. And on page 390, there's a table 20-5 that talk about the pharmacological and the psychological approach, psychosocial approaches that you want to use. Working with the cause can actually help the nurse to understand what interventions are needed. You know, is it the medication? Is it something that's psychological, or is it physical? And so again, they list the drugs that we can use for help with treatments. Health and teaching, explaining that sexual practices vary helps to reduce patients' anxiety about the topic by normalizing the full range of sexual practices. So whatever the patient's situation, the patient can actually feel comfortable sharing. Discussions need to be non-judgmental, and others that may be involved can be counselors, a GYN, a urologist, marriage counselors, psychiatrists, and pastors. Another issue that we're seeing a lot more of is gender dysphoria. It's coming more and more out in the forefront, and we've seen some shows that actually deal with this, and there's a YouTube video that I've attached that you can review. It's a psychiatric disorder that mostly addresses gender preferences and cross-gender activities, which is a gender identity disorder. Gender identity is usually established by the time a child is 3 years of age. Dysphoria is when those individuals have feelings of unease about either their maleness or their femaleness. An individual with gender dysphoria feels at odds with the roles that are associated with that gender. So a child with this disorder is likely to engage in play associated with the opposite sex, such as a girl playing army with the boys. Many times when I talk about the gender identity, many times by 2 or 3, you say, "Who are you?" And they say, "I'm a boy." And they were born a girl, given a girl's name, dressed as a girl in the past, but they always identify themselves as a boy. They want their hair short. They want to do all the boy things. And then this feeling never goes away, and then this becomes a challenge. We do see a lot of psychological issues. They go through a lot of bullying, finger pointing, and so forth, as you can imagine. But this is something that is really going on with them. They actually truly believe, and it's not a homosexual issue, is actually identifying with a certain sex that they feel like they are. And some actually go on further to start having the hormones to help them with either if they need the female hormones or the testosterone towards the male hormones. And then now we are now seeing surgeries to help with that identifier and helping them to make that change. The paraphilic disorders, these are sexual disorders. They are defined as an activity that is usually socially atypical and has the potential to disrupt significant relationships and may even result in insult or injury to others. Your pedophiles and other persons with paraphilic disorders can be at risk, increased risk actually, for self-harm that's associated with the guilt, shame, and anger that they may feel about their behavior and its effect on their families, their victims, and the victims' families. They also face considerable losses, such as the end of their careers or the loss of freedom to imprisonment. Safety is going to be a priority issue for your assessment, especially if they have voice views on harming themselves and or others. I will tell you in the nursing process when we do the assessment, again, you always want to assess for any type of harm that they may cause themselves or others. And also, what is the presenting problem? So one thing that will help is trying to get their perception on the impact of the sexual disorder on their current illness or what's going on with them. So what kind of impact does it have, and what perception do they have of it? Do they see it as wrong but they can't help themselves, or they don't care, or what is it? So that's something that we really want to look into and we want to focus on when we're doing our assessment. Also, we also want to think about, do they have depression? Do they have the suicidal ideation? So again, this is something really important that we need to think about, because they may have mentioned something and then they've been ostracized or criticized, and how is that affecting them? So definitely want to look at this in your assessments. Listed here, you see some of the nursing diagnoses that are associated with this. As far as the outcomes for some of these, you do need to make sure that you try to have some kind of contract, a behavioral contract, drawn up and agreed upon. It should clearly outline rules, expected behaviors, and consequences for misbehaviors, and of course rewards for following the rules, especially if they are in-house or inpatient. The family therapy, this works well, and the work is actually based around boundaries and communication issues with the family. And then in our planning, we also want to focus on safety and any type of crisis intervention to assist with this, whatever issue it may be. Again, they want to express some type of control over their lives, and refrain and manage their urges and refrain from being destructive. as well as self-destructive. They also need to know that there are actually personal sexual boundaries that they should not cross. They also need to control impulsive actions as well. Our intervention is going to really focus on health teaching and health promotion and safety. We're also going to look at behavioral management, about sexuality. We're going to work as a team and think about safety as well. It's best not to be alone in a room with these individuals because of things that might be said or done, and so you want to protect yourself, and also a he said, she said type of situation. There are also some pharmacological interventions that can be introduced as well, such as like a testosterone inhibitor or some type of progesterone. And again, they want to reduce levels of testosterone, especially to repeated sexual offenders. So there may be some there also with some of them may need some like Prozac for some of the disorders to help along with those issues that are coming up. I'm not going to really go into a lot of the pharmacological interventions for these types of disorders. I mainly want to talk about what they are, the diagnosis, and some of the outcomes that we want to head for, and the interventions. We need to enhance self-esteem. We need to also work on behavior modification and their social skills. In sexuality, we need to think about the behavior management. So they have some really good interventions for paraphilic disorders on page 396 in your textbook. That kind of goes over some of the things that we're working on and some of the tasks and skills that are needed to take care of these individuals. The state of Virginia requires us to report child abuse, physical, sexual neglect, and this is the link for that if you'd like to look on there and just see the topics and see how this site is run. A woman complains to the nurse, "It hurts when I have intercourse." Which diagnostic term applies? Look at the available answers and pick the one you think. Genitopelvic pain penetration disorder also was formerly known as dyspareunia. So you figure out which one is easier to pronounce. But anyway, that is the correct answer, is A. I'm going to go ahead and tell you that this question the answer will vary depending on your thoughts and your views. But as you read through this question, so do you believe he will ever acknowledge his guilt? Most of you will probably mark B, I'm thinking, which would be no. There are limited treatment options for paraphilias. And so please look on page 393 through 395 and page 397 to give you some ideas about these disorders for these types of patients.